Hello, welcome to Unit 5, Lesson 2, where we will be reviewing separation anxiety disorder. And the verse guiding this lesson is from Mark chapter 10, verse 27. Jesus looked at them and said, "With man this is impossible, but not with God. All things are possible with God." Sometimes separating from a parent can seem like an impossible task for a child with separation anxiety, and they are often filled with great fear, and we can see tantruming and clinging, and it can be quite impairing. Parents often cannot go to work or focus on work, while the child often will have some school refusal as well. So it is quite impairing. So let's take a look at some of the symptoms and treatment for this condition. Of course, we know that separation anxiety disorder does occur as a stage. Um, but when it becomes beyond what is expected at that developmental stage and it starts impairing and interfering with one's daily activities, it may meet criteria for a disorder or separation anxiety disorder. And so, this is when we see a child that's having abnormal reactivity to real or imagined separation from their attachment figures. And it must interfere with their activities as well as be lasting longer than 4 weeks and begin before the age of 18. It also must have significant distress or impairment in the child or the family, and is again beyond what is expected at that developmental stage for that age. So, of course, we have a preschool age child going to preschool for the first time, having a great difficulty in transition, and that may not meet the criteria for a separation anxiety disorder. And the epidemiology of separation anxiety disorder is pretty common. So we have a prevalence of 5 to up to 25% worldwide. And it is usually not assessed or addressed until a child is refusing school or having somatic symptoms. And it does account for half of all anxiety referrals in childhood. And there is different diagnostic criteria for adults. So we are going to be focusing on that specific to childhood. Separation anxiety disorder does have significant negative psychosocial outcomes, as it can be very impairing in the academic development as well as social development of the child. Children with separation anxiety disorder are predicted to have an increased risk for panic disorder in adulthood. And the clinical presentation does show the hallmark symptom or cardinal symptom of excessive distress or fear with separation from the attachment figure, which usually is the parents or guardians. And it has three specific characteristics. One is that there's excessive or persistent fears or worries before and at the time of separation. So the child has quite a lot of ruminating and worrying about upcoming separations, as well as extreme distress, often tantruming, or extreme behavioral issues at the time of a separation. Many times, a child will tell me that they fear that their parent is going to get into an accident or get sick and die. Um, Another characteristic is the experience of behavioral and somatic symptoms before, during, and after the separation. Many children with separation anxiety disorder have stomach or GI complaints as well as headache. I would say GI distress is one of the most common. And another characteristic is persistent avoidance or attempts to escape this separation situation. So they will try to do whatever it takes to change the situation. Many kids request to be homeschooled. And so, obviously, for a child with separation anxiety disorder, making a decision to homeschool might on the surface sound like a good idea, but it's really not. So, really, the treatment of the separation anxiety would be a much better approach. Not that there's anything wrong with homeschooling, of course, but in these situations, these are kids who previously had been doing well, going to school, and then suddenly, again, because of the separation anxiety, start talking about a desire to homeschool. Many of them want to do virtual or homebound, education. So they'll do, anything to try to escape separating. So it's important to be aware of that. And so here we have a constellation of symptoms broken down into three categories. So, number one is the worry. So, what is the child thinking about or worrying about internally? And oftentimes it's that something will happen to their parents, or that the parents will disappear, or that the child will get lost. They worry that the parents will forget about them, forget to come pick them up. They worry about something happening to them, such as being kidnapped or killed. And many of them worry about, again, parents' safety as well. Behaviors that you're likely to see with a child with separation anxiety disorder is crying at the time of separation or with an upcoming separation. And again, clinging. I mean, these children are clinging onto the parent's leg or onto their arm in the car at drop off, and they're just trying to do anything they can to avoid a separation. There's a lot of complaining. They're complaining about these somatic symptoms, and or they're complaining about reasons they shouldn't go to school. The teachers are terrible, the kids are bullying. They'll come up with tons of complaints. And searching. So here you might see the child is constantly, especially young children, searching, looking around for their parent, and or calling on the phone. And today, with kids with cell phones, you can see kids that are giving 50 to 100 calls or texts to a parent a day, just checking in often. And so the physical symptoms or somatic symptoms that are often reported, again, most common, we have headaches and abdominal pain. There can be nausea and vomiting along with that as well. And kids can have some episodes of fainting or dizziness, dizzy spells, cramps, muscle aches, chest pain or palpitations, nightmares, sleep disorders. So a whole constellation of physical or somatic symptoms. And let's take a look at this case study. Marina is a 9-year-old girl who lives in a large city with her parents and her 4-year-old brother. She is doing fourth grade at a private school. Since she started kindergarten at the age of 2, her teachers noted that she was shy and would only start relating to her classmates by the end of the school year. During the first months of the school year, she spent much time as possible with her tutor, even avoiding contact with the rest of the teachers. Transition to preschool had been difficult, but she managed to make some friends by the late trimester. After that, although she appeared distressed at the beginning of each school year, she managed to relate normally to her classmates. At the age of 9, Marina had the flu, which made her stay home in bed for 2 weeks. When she got better and was allowed to attend school, she cried impatiently, clinging to her mother while begging her not to go. After a few days, she managed to return to school without excessive crying. However, in the middle of the morning, she began complaining of abdominal pain and had to return home. Her pediatrician found no evidence of abnormal pathology. Another day, she felt very tired at school, dizzy with headaches. Again, the pediatrician found no evidence of pathology that would explain her symptoms. But her parents were worried about Marina's problems and went to see a different doctor who conducted more tests that were all negative. She never experienced these physical problems on the weekends. But when Sunday night arrived, she became anxious about presenting the same symptoms to school again on Monday. Now, this clinical vignette highlights the symptoms of social anxiety that can often precede separation anxiety disorder. The viral syndrome that triggered the onset of the social anxiety disorder, and then the problems with separation and the non explained medical symptoms upon separation. So here we see in this case a child that has a history of social anxiety disorder. It took her months to really warm up and to connect with schoolmates, and she had a lot of distress at the beginning of every school year. And so, as we know with anxiety disorders, they do often persist. And then at the age of 9, she had the flu. There is often a precipitating factor that can trigger separation anxiety as well. Now, just like in adults with panic disorder, children with separation anxiety disorder have multiple somatic symptoms that are, of course, very real to them. They are really experiencing these symptoms, they're not feigning them, but yet there is no organic cause. And so oftentimes they will seek um, multiple providers, diagnostic tests, examinations, just to try to find an answer before getting diagnosed with the separation anxiety disorder. And so here we have the diagnostic criteria for separation anxiety disorder, and the child must have 3 out of these 8 symptoms, and they must be recurrent with excessive anxiety. So that's either distress about separation, worry about losing or harm coming to the attachment figures, worry about getting lost or kidnapped, school refusal, uh, being alone or away from the caregivers is very distressful, so they'll be refusing that. And often will refuse to sleep away from caregivers. And even with grandparents or going on sleepovers with friends, even if they had previously been doing that. They may have nightmares about separation, about getting lost or kidnapped or harm coming to the parents, and the experience of physical complaints. So, again, at least 3 of those. And these symptoms must be lasting for a duration of at least 4 weeks. These symptoms have to occur before the age of 18, and they are not explained by another psychiatric disorder, and there must be a moderate level of impairment. And here is a list of some common triggers that can occur to cause symptoms of separation anxiety or the development of separation anxiety disorder. And that can be drop off at daycare or preschool, entering school, boarding a school bus, bedtime, being left at home with a babysitter, or going away to summer camp, moving or relocating, spending the night out at grandparents or friends, uh, parental separation or divorce, the change in friends or loss of friends, the experience of bullying or medical illnesses. So, again, these can trigger the experience of either symptoms of separation anxiety or the separation anxiety disorder itself. Separation anxiety disorder is the most common anxiety disorder of childhood. The peak onset is thought to be between the ages of 7 to 9. And while there's not a lot of data, some studies do indicate the prevalence to be about 3 to 5% of children and decreasing with age. It does usually resolve by adolescence, With treatment, however, and without treatment, a third of the cases can persist into adulthood. It's considered the seventh most common lifetime disorder, and the adult prevalence is said to be 6%. Now, unspecified separation anxiety disorder is much more common, meaning that many children have some of the traits of separation anxiety disorder, but they do not meet the full criteria that we talked about earlier. And so in those cases, we consider that an unspecified. Um, and it is said to be more common in girls, African American populations, as well as some lower socioeconomic areas in the US. We may see more cases. But again, it is the most common anxiety disorder of childhood. So we talked about the need to differentiate separation anxiety as a trait versus a disorder. Some anxiety with separations is very normal, especially at different developmental stages. So it usually does peak at the age of 9 to 13 months, and it decreases after age 2. Age 3, we tend to see more autonomy, and around age 4 or 5, we see some increase as well. Of course, children are often going to preschool or kindergarten at that age as well. It is more common when a parent has an anxiety disorder as well. And so there can be a genetic predisposition, again, as well as those environmental factors. And it's important to remember that the diagnosis is not made before the age of 5. Children that develop separation anxiety disorder at a younger age are more likely to have a remission. And here are some additional predictors for the achievement of a full remission. And we do have nature and nurture going on here with both biological and environmental risk factors. A large scale twin study did show the heritability to be 73%, which is quite high. And anxiety disorders are 5 times more likely if the parents are anxious. And we know the physiological response of fear is that fear conditioning can cause changes in the fear reward circuits, which are the amygdala, orbitofrontal cortex, and the anterior cingulate cortex. And here are some of the family characteristics that have been associated with a child with separation anxiety disorder: low parental warmth, little child autonomy, overprotective and over-involved parents, insecure attachment with the mother, anxious mothers, severe parental discord, the experience of separation or divorce, parental physical illness, parental mental illness, parental job loss, an egocentric, immature, unstable, or antisocial father, exposure to family violence, and the birth of a sibling can be a precipitating factor. And so, additional risk factors include the experience of stressful life events or adverse childhood events that we previously discussed, as well as exposure to a disaster or crime. And some characteristics of the child that can be a risk factor include the experience of behavioral inhibition and low tolerance for humiliation or embarrassment or fear of failure. Depression is also a risk factor and can occur comorbidly. And again, it does occur more frequently in females than in males, and oftentimes will have low achievement in school and sports. So these kids aren't oriented towards academics or participation in sports. And there is a association with the experience of being bullied and the development of a separation anxiety in young children. And the common comorbidities occurring along with separation anxiety disorder include other anxiety disorders, such as social anxiety disorder, or specific phobia, or even generalized anxiety. The experience of a depressive disorder, either a major depression or a persistent depressive disorder, disruptive behavior disorders, and that does include oppositional defiant disorder, disruptive mood dysregulation disorder, and it can also include specific phobias, school avoidance, major depression, bipolar disorder, as well as attention deficit hyperactivity disorder. So, to make a diagnosis of separation anxiety disorder, it's important to assess the child's behaviors. And so, certainly, you may see some of this clingy behavior at a separation or meltdowns, as well as thoughts. And those would be the worries about harm coming to themselves or harm coming to their parents. And physical symptoms, again, eliciting those somatic symptoms that occur during times of separation or during anticipation of separation. So you want to use a multi-informant, multi-method approach and involve the child, the school, as well as the caregivers. You are likely going to need to use a structured or semi-structured interview. And we have talked about some of those, such as the KSADS, the Kitty Schedule of Affective Disorders and Schizophrenia. And as well, we have the anxiety disorder interview that's available. For the preschool age population, you'll want to use the preschool age psychiatric assessment. Okay, and differential diagnosis. So remember, with the differential diagnosis decision making tree, one of the things we're considering is whether there is a different mental disorder going on. So, certainly, we talked about some common comorbidities, but you also want to consider if they meet criteria for any disorder at all, that perhaps there not may not be a disorder. A parent may be bringing a child in and they're very concerned about their behavior during separations, but it may be during one of those periods of development where this is a normal developmental stage. So the differential diagnosis, we're looking at the experience of normal development. Is there a medical illness going on? So are some of those somatic symptoms very real and physically of physical origin? And again, other anxiety disorders are a common comorbidity, but sometimes symptoms overlap. So it may not be that they do have both. They may meet criteria for one or the other. They may have anxiety at separation, but also anxiety throughout the day in many different settings. So it's important to see what is impairing and really, look closely at the diagnostic criteria, the DSM-5. But again, that KSADS schedule interview, the semi-structured interview, that's going to really help you to elicit whether is it which diagnosis or if there are any that are comorbid. The experience of depression, substance use, inappropriate educational placement. Are there some real issues going on at school? Some real reasons that they don't want to go, such as violence or bullying at school? Are they having an adjustment reaction and a grief reaction? And again, is it just behavioral? Is it truancy? They just don't want to go to school. It's important to rule out organic or physical causes for some of the somatic complaints. And so that would be to consider, is it possible that there is an anemia, some type of infection, a hyperthyroidism, heart conditions such as a mitral valve prolapse, asthma, GI issues, diabetes, the exposure to lead or mercury, and or even the development of a brain tumor or seizure disorder. Now, while it's important to consider these possibilities, it's equally important to avoid unnecessary tests. And how do we treat separation anxiety disorder? Well, certainly we have a number of psychotherapeutic interventions that are well documented, have a lot of evidence supporting their use. And certainly the first thing that's important is going to be psychoeducation, really making sure that the child, the parents, the teacher, that they all understand what separation anxiety is and that it is not the child just being willful. And so from that, we can progress to developing a behavior management plan. And that's where we want to use some systematic desensitization, where we may have the child go to school for an hour at first, and then increase to 2 hours, then to three, with some positive reinforcement along the way. Exposure therapy could include instructing the child on some relaxation exercises, grounding techniques, coping tools, and also, again, exposing them to more frequent separations as they practice these tools. And it's important to have these interventions occurring both at school as well as at home. Cognitive behavioral therapy is also helpful, where it's important to confront some of those distorted thought patterns, such as I might get kidnapped, where we can challenge that. Well, have you ever been kidnapped before? Do you have any friends who've been kidnapped? Is it likely to get kidnapped going from your mom's car into the school in the car line? The school is locked. We have the police officer, resource officer. So, really walking them through challenging those distorted thoughts. And often that'll be with some exercise in journaling or drawing pictures for younger children. Pharmacological treatment can be utilized as well, especially if the psychotherapeutic progress is slow or not happening. And while there are no specific drugs that are FDA approved for use for children for separation anxiety disorder, we do have several, including Celexa, Lexapro, Prozac, Paxil, Zoloft, and Effexor, that all have some evidence supporting their off label use for the treatment of separation anxiety.